Good afternoon, everyone. I am Ann Page. I'm PTAC staff in HHS's Office of the Assistant Secretary for Planning and Evaluation, otherwise known as ASPE, and I'm the designated federal officer for this committee, PTAC. I'll be getting this webinar started with some background information, but quickly turn things over to Dr. Robert Berenson and Mr. Harold Miller, who will be presenting the major points of this presentation. And just a few words to introduce them if you don't know them already. Dr. Berenson is an Institute Fellow at the Urban Institute in Washington, D.C. He also serves as a board member of Catalyst for Payment Reform and Health Connect ACO, and is a member of the WellPoint Physician Advisory Council. In a previous life, he served as Commissioner on the Medicare Payment Advisory Commission, otherwise known as MedPAC. And Mr. Harold Miller is President and CEO of the Center for Healthcare Quality and Payment Reform, a national policy center that develops and encourages implementation of national, state, and local strategies for improving the quality and reducing the cost of healthcare. A reminder again that this webinar is being recorded. The slides used in this webinar, as well as the webinar itself, will be posted on the PTAC website after this presentation, and those who have registered for this webinar will receive copies of the slides. Following the presentation, you can ask questions from the operator, and you can also use the chat function. So for today, we want to discuss some specific information and issues that PTAC thinks can be helpful based on the PTAC experience to date with proposals submitted and the questions we are frequently asked. We want to point out, though, we will not be covering every aspect of the proposal review process or every element of the proposal contents. More details on both of those were covered in 2 prior webinars that are still accessible from the PTAC website. So if you do go to the PTAC website, you can see the first webinar, which was entitled Overview of the Physician-Focused Payment Model Technical Advisory Committee, PTAC, or the webinar on how to submit a proposal to the Physician-Focused Payment Model Technical Advisory Committee. Before Mr. Miller and Dr. Berenson share some clarifications and tips for individuals and organizations who would be submitting proposals, in this slide and the next 4, we want to quickly review some basic information on how to submit a proposal and what you can expect when you do. So if you look to the far left, you'll note that a letter of intent is required at least 30 days prior to submission of a proposal. For planning purposes, we want to point out that what is in your actual proposal could be different somewhat from what's in your letter of intent. PTAC uses these letters of intent primarily for planning purposes. This just gives us a heads up about the volume that we can expect and the general topics that we can expect that we might need some expertise on. We do want to point out that if a party is thinking of submitting multiple proposals, they would need a letter of intent for each proposal. Once a proposal is received, PTAC is aiming to have its review completed within 16 weeks. This can be faster or it can be slower depending upon the volume of proposals that PTAC receives and the nature of the proposals. And then PTAC then deliberates on proposals during its meetings open to the public. Advance notice of all these meetings is published in the Federal Register. Submitters will also be invited to attend those meetings. And then the output and the results of the public meeting are that the PTAC makes comments and recommendations to the Secretary. And those recommendations are to either implement or not implement. And then the final step is that by law, by MACRA, the Secretary must respond to the comments and the recommendations made by PTAC, and the Secretary's comments will be posted on CMS's website. That's sort of the general approach that PTAC uses and what you can expect for each of those stages. Again, just to point out a couple of things, that letters of intent and Full proposals should be submitted through a submission system that's on PTAC's website. So if you go to our website, you will see a portal for the submission of the LOIs and the proposals. All letters of intent and the proposals will be posted on the PTAC website for the public. Members of the public are invited to make written statements on proposals, and then all written statements will be sent to me, the designated federal officer, for PTAC at our website. In general, PTAC is reserving 3 weeks for the submission of public comments on a proposal, and then public comments received will be added to the website approximately 1 week after the conclusion of the comment period. And these 2 items, these 2 bullets that I just reviewed, these are all in service of the PTAC's commitment to transparency in its processes. Transparency about the proposals that we've received, transparency in the information that PTAC is reviewing, considering in its review of proposals, transparency in PTAC processes, and transparency in PTAC deliberations. After a proposal is submitted, a subset of PTAC members are appointed to serve as a preliminary review team. And then after reviewing the proposal, the PRT may ask questions of submitters to help better understand a proposal. So if you are a submitter, you should probably expect so far, I think all of the preliminary review teams have always had some questions to go back to submitters. These questions and responses ultimately need to be in writing, and they will be posted on the PTAC website for review. If you would like to review the proposals submitted to PTAC, you can find them on 2 different locations in the PTAC website. First, proposals are first posted on the public comment tab of the PTAC's website. You're looking at a screenshot of this tab. And again, on the prior slide, I mentioned that the public is invited to comment on proposals. This is what you would see if you wanted to make a comment on the proposals. So this is the first place that you can find proposals. Once the comment period is over, however, you can still find all the proposals, and you can see this today. You can find all the proposals that have been submitted to PTAC on its website, even after the close of the public comment period. A couple of key deadlines and a timetable. Again, a reminder that LOIs can be submitted at any time. PTAC is open to receive letters of intent 365 days a year. And then subsequent to the submission of a letter of intent, proposals also can be submitted at any time, 365 days a year, if it's at least 30 days after the letter of intent has been received. Third point, if a PRT has questions for you, the submitter, the submitter can respond to those questions whenever it's convenient for them. The PRTs have been really committed to providing submitters with sufficient time to really explain their proposal in sufficient detail. So I think the PRTs have really worked to accommodate whatever amount of time it has taken submitters to respond to questions. However, the PTAC can only make recommendations on a proposal after it has received all of the information it needs. So the speed with which submitters reply has implications for the speed of the PTAC's review. And the fourth point is that PTAC can only make recommendations about a proposal at a public meeting. Again, so the total amount of time that it's going to take for PTAC action really depends both on how quick, the number of questions, the number of responses, how quickly it takes a submitter to get those responses back to the PTAC, and then we have to match that up with the PTAC's meeting schedule. A final point, there's no limit on the number of proposals that PTAC can recommend. PTAC can recommend a proposal that it addresses an issue similar to something that it has already recommended, if the PTAC believes that the proposal meets the criteria that are in regulations, the Secretary's criteria. And then once the PTAC makes its recommendations, and if the PTAC has recommended favorably that a proposal be implemented, it's up to HHS to determine when those proposals will be implemented and when. So with that information as background, I want to turn things over to Mr. Miller and Dr. Berenson to speak to how to submit a proposal, that can really facilitate a ready attention by the PTAC.
Great. Thanks, Ann, and hi, everybody. It's a pleasure to be with you today. I'm glad you had time to join us. One thing I think Ann didn't cover was just that there is the RFP. I'm going to be covering a number of the things that are in the RFP, but I would encourage everyone to, if you haven't, download the request for proposal document as well as the material about the letters of intent and read that, because that provides a lot more detail than we can cover today. And as Ann mentioned, there's an earlier webinar that covers that. So first I wanted to describe a little bit about the basis of where the PTAC's basic criteria come from, and then Bob Berenson and I are going to cover some advice that we have based on our early experience with reviewing proposals to date. First of all, we are the Physician-Focused Payment Model Technical Advisory Committee is limited to focus on what are defined in the law and in regulation as physician-focused payment models. And you can find these in the regulations that were issued under MACRA, but an alternative payment model is something in which Medicare is a payer, in which eligible clinicians or professionals play a core role in implementing the payment methodology. So this is not payment models that might be specific to hospitals or to skilled nursing facilities. It's something that involves clinicians, and it's important to recognize that in the regulations, although they're called physician-focused payment models, the regulations expanded that term to include eligible professionals, which includes physicians, physician assistants, nurse practitioners, clinical nurse specialists, physical therapists, a variety of different clinical professionals. And the payment model needs to focus on the quality and cost of services that those professionals either provide, order, or can significantly influence in some fashion. What it does not have to be in terms of the submission to PTAC is it does not have to be an advanced alternative payment model as Medicare has defined that. And the PTAC itself is not going to make a determination as to whether it meets those requirements under CMS regulations. So the PTAC will consider things that may qualify and things that may not qualify as advanced APMs. The criteria that we use also come from the MACRA regulations, which were promulgated by the Secretary of Health and Human Services. And in those regulations, there were 10 specific criteria. So the PTAC's role is really determining whether a proposal that is submitted meets those 10 criteria and thereby deserves a recommendation to the Secretary. And they are listed on the screen. They're broken into 3 different categories in the regulations. But the 10 criteria are value over volume, flexibility, quality and cost, payment methodology, scope, ability to be evaluated, integration and care coordination, patient choice, patient safety, and health information technology. Now, what we have done in the RFP is a couple of things. One is that we have identified what we believe are the highest priority criteria. These are criteria that we have established as the PTAC, saying that we think that the proposal must meet all of these criteria. That's the scope of the model, whether it's doing something that goes beyond what is available today in terms of alternative payment models, how it addresses quality and cost, and how the payment methodology works. There are other criteria which we have not determined to be high priority. So if a proposal doesn't fully meet one of those, it's possible that we could still recommend it. But we've determined that the high priority criteria are essential for recommendation by us. So that's where the criteria come from. And what you can find in the RFP is more detail about those criteria. So in responding to the RFP, it's important to answer, provide information about each of those criteria, because that is really what we are required to do by law and by regulation, is to evaluate the proposal against those criteria. We have in the RFP identified a series of specific questions related to each of those criteria to try to help applicants understand the kinds of things that we will be looking for. Now, the questions are not all mandatory in the sense that you may well be able to address the criteria, a particular criterion, without answering every single question that we have listed. The questions are really there to try to help people understand what it is that we're going to be looking for. But I would also say that if a question is applicable to your proposal, you should try to answer it. Because that is the kind of question that we would end up asking in a follow-up anyway. So it's very important to pay attention to all of those criteria and all of those questions and provide us as much detail as you can on each of the criteria so that we can provide a full and effective review of those. Obviously, the high priority criteria are the highest priority to address, but we need to, we will need to make our recommendation based on all the criteria, so we need information with respect to all of that. Now, the question, of course, people raise is, well, how can you address all of those 10 criteria and all of those questions in a limited space? So what we've asked for is that within a 20-page proposal, that information adequate to assess the criteria should be included in that 20-page limit. But appendices can be added to provide additional details. So if there is something that you can describe briefly in the main proposal, but it requires really more detail to try to explain clearly, then I would suggest that you put the basic material, the basic essential information in the 20-page proposal and then provide an appendix for us to review. What we said in the RFP is there is no guarantee that every member of the PTAC will review all of the appendices. So it's very important that the key material be in the proposal, but you're welcome to provide additional information in the appendices. And facts and data are the most convincing and objective way for us to assess the criteria. We are not looking for those who have the best rhetorical skills in terms of trying to convince us as to the merits of the proposal. We're really looking for as much facts and data as possible. Now, what Bob and I are going to do next is try to provide some real, just some tips, some suggestions, and we're doing this based on the proposals that we have seen so far. But recognize, for everyone, recognize that we're very early in the process. We have not yet even been to a public meeting for a full PTAC discussion of any of the proposals. So our thinking may well evolve as we get more proposals and as we have discussion. And Bob and I will try to give you some insights today, but we are only two of members of an 11-member group, and other people may have somewhat different points of view about various aspects of this. But one major suggestion that we want to offer is that it's really important in the proposal to try to explain the problem that you're trying to solve. This isn't just about trying to invent a payment model that's different than every other payment model that may exist. The idea is, what problem are you trying to solve? And in fact, the Affordable Care Act speaks explicitly to the idea of trying to fill gaps in care. So we hope that in a proposal, the proposal will explain what improvements in care delivery are going to be supported by the proposed payment model, why those care delivery improvements can't be implemented under current payment systems or with relatively simple adjustments to the physician fee schedule, and why those payment barriers aren't addressed by any existing payment demonstrations and a new payment model is needed. One of the criteria that we have to meet is to show how a particular proposal actually expands the portfolio of demonstrations. So if a payment model is doing basically the exact same thing that already exists, then it is not likely to be recommended. So Bob, other comments you want to add on that point?
Yeah, let me just make a couple of points. Number one is, if you've, in the front of your proposal, have laid out important problems that exist in the delivery system and that current payment methods are not addressing, and therefore you want to have a new payment model, when you get to describe how that payment model is going to improve the situation, address the problem you laid out in front and not some other problems. This goes to the whole issue of the previous slide, which says be clear. My experience so far in this process has been that there's been something of a mismatch between the problems that are being identified as important and how the payment model will address those problems. So to the extent that 20 pages seems too short to you, as Harold said, the most, but maybe not everybody on the PTAC will review all of the appendix. But the 20 pages should address the concrete stuff, the three major criteria that we are most interested in, which is the high priority criteria, the scope of the payment model, how it will affect quality and cost, and a clear description of the payment methodology itself. And if that means you can't do as good a job on some of the other criteria, at least nail that one. How, clear writing, we've got these problems, and here's how this payment model is going to address them. And the other point I would make is that it can be challenging for both the proposer and for the PTAC to address issues in which there could be simple fixes. Well, simple is a relative term. Straightforward fixes or simple fixes for the current moment in the Medicare fee schedule or in some other demonstration approach, but there's either statutory or regulatory barriers to doing that. So here's a new payment model. The challenge will be, did we really need a new payment model to address that, or can we actually go revisit those barriers in current law or regulations? We very much, and we've got a slide coming up in a few minutes that will talk about which kinds of payment models we would give highest priority to, that doesn't. So we will have a issue of a payment model is trying to use an APM to do what we could do just very straightforwardly, and that will be a challenge again. We would want the payment models to really be broad in scope and not just fixing something that otherwise could be fixed. Harold, back to you.
Okay, thanks. We need to have details about how the payment methodology would work. So as clearly as possible, explain that. So what would be different about the way physicians or other entities would be paid than they are today? And again, physicians may include other eligible professionals. How would accountability for quality, utilization, and spending be different than it is today? How would the methodology assure that the payment amounts for services the patient need are adequate to be able to deliver those services? And how would the methodology ensure that if there's savings to be achieved in one place, that it's not being offset by higher spending elsewhere? So those are at least some aspects of the payment methodology that need to be clarified. That's not a comprehensive list. We need to understand, because obviously the payment methodology may differ from proposal to proposal. But those are some key elements that we think need to be explained so that we can understand how the payment methodology would work. Bob, anything you want to add there?
Only thing to add is at least the first three bullets strike me as very useful for you, not only for your internal deliberations on how you're going to write up your proposal, but even to put it as something of a summary of, if you can answer those three questions in a very precise way, even explicitly, as sort of, I've given you lots of detail, here's the summary of it, that will be very, very helpful to us. Again, I would emphasize clear and concise. In the first round, when we're reviewing a proposal, first impressions count. To the extent that you're not able to provide some of the nuance that you think we might want to get into and that we will want to get into, that can come as we sort of ask back questions of how are you dealing with this, how are you dealing with that. The first presentation should be clear, concise, and to the extent that you want to have a relatively small amount of text that very clearly answers questions like these three, that would be helpful to hammer home the point of the proposal. Back to you, Harold.
It's obvious, as I said, facts and data are really important, and we need to understand something about the impact of the model on quality and cost. Under the law, alternative payment models must either improve quality without increasing cost, reduce cost without harming quality, or improve quality and reduce costs. And so we need to understand what you're expecting the model will do and what kind of an impact you think it's going to have. So what aspects of care quality or outcomes are going to be improved? How would that be measured? Where exactly are the savings going to be achieved, and what mechanisms are going to be used to ensure that savings offset any additional costs? So how much is it going to cost to deliver any new services that are going to be supported, and how do the savings offset that? How many Medicare beneficiaries could potentially benefit from this? Because obviously there may be small models that could be helpful to those beneficiaries, but given limited resources, it may be more challenging to implement very, very small models. And we want to understand as much as possible how much quality will improve and what kinds of savings are going to be anticipated during whatever initial time frame you're anticipating for the proposal. Now, we understand that it is challenging to get data today, and I'll come back to that in just a few minutes. But the fact that it's challenging to get data does not mean that you shouldn't provide data at all. We need to understand as much as possible what your estimates are, at least, of these impacts. Bob?
No, I don't have anything to add to that one. Go ahead.
Okay. Key thing is we're certainly interested and happy to have people who are actually in the field and who are seeing kinds of improvements that they want to make and seeing barriers in payment and want to fix those. But the model that you propose can't just apply to your own practice or organization. These have to have the potential to be used by physicians and other eligible professionals across the country. It doesn't mean that every single physician needs to or wants to use it, but it means it has to be more than one organization. So while at one extreme we don't want theoretical models that no one is interested in, we also want to know that there are multiple physicians who might be able to use the payment model if it is implemented. So we're really not likely to recommend a model that's only designed to work for one particular organization in one community or one very small collaborative, particularly if there are some unique features that would mean that it would only work in that narrow circumstance. So it's okay that the proposal supports the kind of services that the applicant wants to deliver, but it needs to be designed in a way that other organizations will also be able to implement it. Bob, you want to add to that?
Yeah, I do want to add to this one. There are payment models that for which there are advocates, proponents, sort of the technical jargon we use are first movers and early adopters. A payment model that in an idealized world would really support good practice, but at least CMS and some of us are concerned about what happens with a payment model that can also be misused by those who are not sort of proponents or they're not early adopters. The model might have to be, well, ideally would be broadly applied. So to the extent that you can anticipate the potential for how somebody who was not necessarily with the program and wanted to take advantage of a new payment model, to the extent that you can anticipate that and head off the kind of concerns that we might note about that in how you've designed your payment model, how to protect it from that kind of problem, that would be very helpful. So think of these payment models as in absolutely improving the ability of clinicians to do the right thing for their patients and to get paid appropriately for it, but how might it be used how would it work for those who maybe were not as enthusiastic about it? Harold, back to you.
One of the things that we would encourage everyone to do is to read carefully the Section B in the RFP, which is titled Characteristics of PFPMs that are likely to be recommended by the PTAC. These are not absolute standards in any fashion, but they were intended to give some sense of what things were more likely to be recommended versus less likely to be recommended. And this slide covers just some of the points that are in that section. First of all, I want to make it clear that we're really open to a very wide range of models. Some people seem to think that everything has to look like the things that CMS has already implemented, and that is not the case at all. We are open to very different approaches to models, again, as long as they meet the kinds of earlier points that we described in terms of they're actually addressing a problem and improving care. We are also more likely to recommend things that are truly different payment models, not just adjustments to the fee schedule. So if the issue is simply that there is some particular service or fee item that is not covered properly in the fee schedule and it might be better addressed there, that's really the way to go. That's not really what the PTAC is all about. We're more likely, this is not again an absolute criterion, but we're more likely to recommend things that replace or bundle payments for all services that are related to a condition, a treatment, or all aspects of a patient care, not just a subset of those services. And if, in fact, you're only talking about changing a subset of services, we'd like to understand why you're not doing anything to the other services and how you will control cost and quality associated with those. And ideally, we'd like to see models in which the clinicians are taking accountability for controlling spending on all the services that are related to either the health condition or the risk factor or the specific kind of treatment that's being addressed by the payment model. Again, this intends to try to ensure that there is not savings in one place that then is being offset by increases in costs somewhere else. So having a comprehensive view of all services that are related. It doesn't necessarily have to be all spending on the patient, but all related services. And it could also be, as we described in the document, for specific factors that are really the primary drivers of that spending, if that would be more feasible to pursue. We're very concerned about models that are trying to achieve savings on an episode of treatment, but that have the potential then for increasing the number of treatments that are being developed. So models that actually address the appropriateness of the treatments, not just the costs of the treatments, are more likely to get a favorable response. We're more likely, again, not an absolute, more likely to recommend models that take accountability for outcomes, not just measures of processes of care. We understand there are a lot of challenges in terms of being able to measure outcomes, but I think there is broad agreement that we need to try to move in that direction. We are more likely to recommend models that have some method of ensuring that the amounts of payments and the measurements are distinguished differences in patient needs. So patients who have higher needs getting more payment and having measures that are stratified appropriately are more likely to be recommended than ones that simply assume that somehow it will all average out. And finally, we're more likely to recommend models in which any financial risk is designed to be feasible for physicians and particularly small physician practices, not things that would only be feasible for large organizations. Let me see what Bob wants to add to that.
Yeah, no, you covered everything I did. I'll just reemphasize 2 points. The fourth bullet there, we specifically did not say that we want the accountability on spending to be for total cost of care for all services that a beneficiary receives. That's certainly one of the options, and it probably makes much more sense for certain kinds of payment models to be accountable for total cost of care than for something narrower related to a procedure or a condition, So we are not requiring and not going to disfavor proposals that do not have total cost of care for all services for a beneficiary. And then the very next one, which actually sounds paradoxical, but it actually isn't, where we're not dealing with a total cost of care environment, say a population-based payment model, but we are talking about a treatment or a procedure. We very much want to be able to evaluate and see how the proposal deals with the potential for having more treatments, more procedures. So the evaluation would look not at just at the procedure costs, the treatment costs, but at the total costs associated with that procedure or treatment, taking into account whether the volume has increased ideally across the community, not just for that particular provider. Back to you.
Thanks. So one of the things that we heard in our early public meetings where we were inviting comments was, and not surprisingly, that one of the biggest challenges that they faced was in being able to get data. And CMS has been much more transparent in terms of making data available, but the data tends to come in individual silos. So you may be able to get Part B data for physicians or hospital data, but not linked together. So what we have tried to do, and we have on the website that you can go and download, a sample analysis. It's called illustrative data, and it's focused specifically on, there's a set of data on heart failure, and then there are some data on other kinds of chronic conditions. And this was really a sample analysis showing what is possible to do by linking together all of the various Medicare data sources. And we would very much like to receive comments on this. We posted this for comments. And if you think that there is a different way of analyzing these data, if you think that there is a specific chronic condition, acute condition, or whatever where that you're interested in doing analysis and you need to have that data, we would very much be interested in getting your feedback, both in what kinds of analyses, what types of conditions and procedures you think analyses should be done on, and how exactly you would recommend specifying those analyses. So this sample is there for you to look at, and if you say it's not detailed enough in the following respect, then tell us how you think it should be detailed in order to help you structure a model. So that's an ongoing, anytime that you have comments on that, we would welcome getting them. I have to say I have been disappointed that we have not gotten more comments on this to date, given the number of people who've said that data is a challenge. We have also made available on the website data that already exists and has been generated by CMS and other areas, and we included a document with a survey of other payment models that are being used. We will, if anyone knows of additional material that would be useful, we'd be happy to post those things also, but here you can find other data sources and analyses that have been done in the past, and they may also be helpful to you. So whatever data that you put into the proposal, obviously it needs to be explained, and if you've made assumptions, we need to understand exactly what assumptions you've made and why you have made them. So whatever data you have used, please, first of all, obviously include data where you can, and then explain the sources of it so that we can understand where that's come from, what has come from, and whether the measures that are being used have been tested or validated. Bob, anything you want to add on those points?
Nope.
Okay. So finally, perhaps most mundane is simply to, before you submit a proposal, make sure you have checked the checklist that we've provided to make sure that all of the things that are required are in there, because we do need to have all of these various pieces of information, and we don't want to slow down the process of reviewing a proposal that you've worked very hard on simply because it's missing certain key pieces of information. So that's perhaps the most mundane part of all of putting together a proposal, but a very critical, essential piece. And finally, before we open for questions, we are welcoming, Ann said this before, we welcome and encourage comments. All of the proposals that we receive are on the web, and we encourage comments. I want to assure you we review all of those comments. We find those comments very helpful to us in understanding potential both support and concerns about the proposals that we've received. We probably have the world's longest URL that's not easily memorizable by anybody. We will try to address that in the future, but please check the website. You will see a lot of information there on the proposals. Best way to know what's going on is to join the listserv. It's absolutely free, and that's the earliest and best way to know whether we've received a new proposal, when we're going to have a meeting. We have a Twitter account, PFPM TAC, standing for Physician Focused Payment Model Technical Advisory Committee. And with that, we're going to open up for questions. There's two ways you can ask questions. You can ask them verbally through the operator, and I'll ask the operator to open the line in just a second. You can also post a question in the chat or question box that you should see on your screen. And to Liz's question, yes, we will make the slides available on the website, as well as a recording of the webinar after the webinar is over. And so with that, I'm going to ask the operator to open the lines, but in the meantime, you're welcome to enter questions into the chat box.
Thank you. Ladies and gentlemen, if you'd like to register a question, please press the 1 followed by the 4 on your telephone. You'll hear a 3-tone prompt to acknowledge your request. If your question has been answered and you'd like to withdraw your registration, please press the 1 followed by the 3. If you're using a speakerphone, please lift your handset before entering your request. Once again, to register a question, press 1-4 on your telephone keypad. And there are no questions over the phone lines at this time.
So I know that those of you out there have questions. You're welcome to make comments too. So we're here. This is like the world's best opportunity to ask a question. Don't be embarrassed. Please type in the numbers and ask us a question, anything that's on your mind. No, there is no such thing as a dumb question.
Once again, ladies and gentlemen, to register a question, press 1-4.
Question that came up in the chat box about the agenda for the March PTAC meeting will be posted. We are working on that. We've had some changes from some original plans that we had, but hopefully within the next few days we will be able to post the agenda for the meeting. Question I see from Glenn Littenberg: how much weight will PTAC give to support, opposition, or lack of comment by professional medical societies? I'll start with that and then let Bob weigh in. I think we're certainly interested in the comments that anybody has in the professional medical societies. I guess I would say the issue is what's the nature, the rationale for either support or opposition. It is much more meaningful for us to understand specifically why someone thinks a proposal is a good idea or why they think it's a bad idea, so that we can, because again, our decision isn't just an up or down decision on something. We are evaluating the proposals based on the Secretary's criteria. So we really, if you want to express comments, it helps us to understand specific concerns or support that you have relative to those criteria. Bob, you want to weigh in on that one?
Yeah, I think it's less important, sort of the political weight of supporters or opposition than the fact that as we're reviewing what are often new and in some cases complex payment models, we can speculate as reviewers on what the impact would be on various clinicians and other providers. And to the extent that there are public comments that help us understand what's involved and whether some of our speculation is confirmed or not confirmed, that would be helpful. I would encourage commenters, both supportive and, if necessary, in opposition, so that helps us do our job, where we can get some confirmation or other about what we might be thinking about.
Let me see, operator, any calls on the phone yet? Any questions on the phone yet?
Yes, we have a question from the line of Pam Cassing of American College of Radiology. Please proceed with your question.
Hi, thank you so much for the presentation today. And I was wondering, what recommendations do you have for specialties as far as submitting models? Because what you describe is the need for models that are very broad, that take over somewhat of an entire disease state or care when a patient has a problem, but the specialties might be involved in only a portion of that care, like preventative screening or diagnosis.
Well, no, I wouldn't want to give you that impression. I think that the issue was that we said it could be focused just on a treatment, it could be focused on a procedure. The issue is if, in fact, it only addresses one particular service associated with that procedure or condition or treatment or whatever, to explain why it doesn't include something else. Where, if it only addresses one piece, what might be the potential impact elsewhere. So we're concerned that if you're saving money doing X, then how do we know that it's not improving something somewhere else? So I think, there's many things, for example, that the non-patient-facing specialties do that I think could potentially help in terms of speeding diagnosis, doing early identification, et cetera, that I think could potentially be either models or potential part of models. I think the issue is, first of all, what exactly is back to our earlier slide, what's the improvement in care that you're imagining? What's the barrier under the current payment system? And then how would you address that through the payment model? And then any pieces that aren't included, why aren't they included? And is there a way to control them, or is there a reason why we shouldn't be concerned about those? Does that help, Pam?
Yes, it does. Thank you.
Yeah, and I would just add the payment model can't improve what would turn out to be a trivial amount of have a trivial amount of impact on spending or quality. It would work very well for interpreting an X-ray of the knee, but not for anything else. So it doesn't have to necessarily cross a bunch of specialists. There may not be applicability of care coordination conceivably in the proposal if it's a specialty-specific approach, but ideally it would affect sort of how care or how the specialty is functioning broadly, not just for a particular limited scope of activity, if that helps.
Let me take one of the questions that came in the chat box from Sharita about the data and comments process. So I think if you're referring, Sharita, to this slide, as I said, we recognize that it's very difficult today to be able to get essentially total cost of care data for patients that it's sorted by condition, by comorbidities, et cetera. So if you look at this is an example of there are several tables on the website, and this was basically a first pass to say how might one do an analysis like this. But one set of examples is there for congestive heart failure. So for example, if you're looking at something else, rheumatoid arthritis or COPD or whatever, and you're having trouble getting data, we would be interested in hearing, well, does that kind of a format, would that be helpful to you? Would there be a more detailed breakdown that you would need to see for that particular condition? Because we would actually like to be able to generate some more of these reports across a variety of different conditions, but we don't want to do the work on that until we get a better sense of what kinds of breakdowns would be useful. So input on that would be most welcome. And it can be specific to something that you're working on. We may end up deciding to do the same approach for multiple different conditions, but we need to hear what would be useful for you. Operator, other questions on the line?
There are no further questions at this time.
Okay. Other questions that came in the chat box, Brill asked a question about how can a commenter provide comments on a proposal if the PRT's questions and proposed response haven't been posted. First and foremost, we would like to get comments on the proposal. The proposal has been posted, and we would like to get comments on that. We are going to ultimately be posting the questions and responses. We didn't quite until recently realize that we were going to be having as much back and forth as we've had in some cases, and so we came somewhat late to the game to realizing that we should be posting those things, and we wanted to contact those who submitted the information to let them know that we would be doing that. But going forward, we're going to be trying to post with reasonable frequency any additional information about proposals that come along. Another question from Dr. Littenberg. Stark laws are currently problematic regarding shared savings administration amongst nominally competing providers and hospitals. Any notion of how CMS will address this for these models that they accept some safe harbors were created for ACOs, for examples? I'll start and let Bob weigh in. I think everybody has recognized, going all the way back to the Affordable Care Act and its provisions allowing waivers, that there were likely going to be some barriers in current law and regulations, not just the payment methodology, that would need to be changed. So what I would suggest is that in your proposal, if there are, and I think we actually mentioned this in the RFP criteria, if there are other barriers that would need to be addressed, say Stark law or other of the fraud and abuse laws, you should identify those. And if you have a solution, you're welcome to recommend it. But if it's a problem, to identify it so that it can be identified as something that would need to be addressed if CMS decides to pursue implementation of the model. Bob, you want to add to that?
No, you did fine. That's exactly right.
Okay. And Sharita also asked a question about the selection process once the recommended proposal is in the hands of CMS. That's really, we have no control over that. Our role is to make recommendations to the Secretary, and then the Secretary, as Ann said earlier, is required by law to respond to that, but then HHS needs to make its own decisions about what is feasible for them to implement. I would just say that I think that the more detail that we have in the proposal, and CMS has indicated this, the more information that's available, the more specifics that are there, the clearer it is about exactly how the model would be implemented and what impact that it would have, would seem likely to increase the probability of a positive decision from CMS. But that will be up to CMS to decide. Operator, any other questions on the phone?
There are no further questions at this time.
Okay. I don't see any other in the chat box, but we still have a few minutes, and if anyone would like to ask a question, you're welcome to, and if you'd like to post something in the chat box, you're welcome to.
Once again, ladies and gentlemen, to register a question over the phone, press 1-4.
I'm going to resist my normal habit of calling on people by name to ask them to ask questions, so maybe that will strike fear in everyone's heart. Any other questions anyone has? We'll give it one more minute to see if anybody has a question. Nothing else, operator?
No questions at this time.
Okay. I don't see anything through the chat box, so I think we can probably then declare an end to this. We will make the slides available. We have posted in the slides, when you see them, there will also be, we included so you can get all in one slide set the slides from the previous webinar we did with more details on the proposal. Again, I would encourage you to visit the website, to look at the proposals that are already there, to look at the data that's already there, to join the listserv, and to attend our meetings as we schedule them, with the next one coming up in about 2 weeks. So thank you all for joining us today, and we will now conclude the webinar.